Good afternoon, everyone. We are excited to present this valuable webinar on some of the CMS model changes for V24 to V28, our coding audits, and our supplemental file submission process. This presentation's recording will be available on our Blue Cross Blue Shield Provider Risk Adjustment webpage. Throughout the webinar, the chat box will remain open for you to submit your questions. We will answer all questions pertaining to the webinar's topic in an email when we send out your CEU. If we are unable to address your question during the session, a response will be emailed to you after the webinar. This presentation has been approved by the AAPC for one CEU. Please note you must attend at least 75% of the presentation in order to be awarded your certificate. After attendance has been verified, certificates will be emailed to you with the email address provided within the registration link. This presentation is intended for both physician and office staff. The information contained in this presentation and responses to the questions are not intended to serve as official coding or legal advice. All coding should be considered on a case-by-case basis and should be supported by medical necessity and the appropriate documentation reflected within the medical record. Before we begin, I want to take a moment to introduce our risk management team and some of our presenters for today. Our team is comprised of nurses and coders that have worked in an array of settings with many years of experience. I want to outline some goals we have for today's webinar. Our goal is not to make you experts with these topics, but we are hopeful you will leave feeling more confident in finding success in our risk program. Include this in topic points. This is an overview of the V28 changes. For full details, please refer to the CMS website. So, with that being said, we have a lot to cover today. So, I'd like to introduce Tracy Cox. Good afternoon, Tracy.
Afternoon, Kira. Thank you. So we'll start with why did B28 happen? So the reimbursement model is based upon a shared risk between providers and payers. The associated risk adjustment model uses past claims data to predict future expenditures, which ultimately lead to provider payments. The model, which was established using ICD-9 CM claims coded data, follows guiding principles to determine which diagnostic conditions are appropriate expense predictors. But when the industry transitioned to capturing and reporting ICD-10 CM codes in 2015, the model used ICD-10 CM codes in providing payments, even though the underlying foundation was still built upon ICD-9 CM codes. Every year, the Centers for Medicare and Medicaid Services, otherwise known as CMS, perform a model calibration based upon updated diagnostic and expenditure data. This allows for changes to the model to ensure reimbursement keeps pace with the industry. You can find a complete list of those changes published on the CMS website. As CMS was preparing for this year's updates based upon model calibration, it was decided that the ICD-10 CM coded claims data was sufficiently stable to predict future case expenditures. This led CMS to clinically reclassify the model from the ICD-9 CM based foundation to an ICD-10 CM based foundation for calendar year 2024. Following the risk adjustment guiding principles, which ensure that classification is clinically meaningful, can accurately predict expenditures, and encourage accurate coding, CMS classified over 72,000 ICD-10-CM diagnostic codes into approximately 1,500 diagnostic groups known as DXGs. Codes are placed in DXGs if they were related in clinical and cost characteristics. Hierarchical condition codes, or HCCs, were then established from the DXGs, creating what CMS has identified as version 28 of the CMS HCC risk adjustment model. The V28 model is a 3-year model blend. As many have heard, V28 is blending into V24 over 3 years. So what does this mean? For payment year 2024, 2023 dates of service are looked at. These dates of service will include codes from V24 and V28 models. Coefficients for codes from V24 will be reimbursed by CMS at 67%, and those from V28 will be reimbursed by CMS at 33%. Coefficients for codes that appear in both models will be reimbursed at 100% by CMS. For the next payment year, 2025, 2024 dates of service are looked at and the same methodology will apply. However, for these dates of service, CMS will reimburse the coefficients for codes from V24 at 33% and those from V28 at 67%. Coefficients for codes present in both models will continue to be reimbursed at 100%. Finally, payment year 2026 for dates of service from 2025 will be V28 codes only, and those coefficients will be reimbursed at 100% of their associated coefficients. During this year, your risk coding provider education and engagement team will continuously call out new codes from V28 during our correspondence with you and your team, as well as get used to seeing them and using them. One shouldn't be chosen over another. Rather, the most appropriate code for that condition should be used. Some codes have expanded to increased detail they reflect. Therefore, coding from memory should be avoided. So, new conditions in V28. Specificity of documentation and diagnostic coding have always been essential for accurate risk adjustment. HCC Model V28 will require even greater specificity in documentation and code assignment to ensure that the true level of your Medicare Advantage patient's illness severity is captured. For example, 268 codes were added to the V28 model. 40% of them are not prevalent in the Medicare population. Here are just a few of the new codes that are going to be recognized with V28. We have anorexia nervosa, bulimia nervosa, severe persistent asthma is now recognized with the CMS folks, and presence of artificial legs. Other additional diagnoses from V28 include alcoholic hepatitis with and without ascites, malignant pleural effusion, obstruction of the bile duct, toxic liver disease with hepatitis. Profile changes made between V24 and V28 include conditions that didn't accurately predict medical cost. Coefficients were small, conditions with unspecified diagnostic criteria for coding, and conditions that were uncommon. Conditions which no longer risk adjust, however, if prevalent, should be coded, such as protein calorie malnutrition and cachexia, major depressive disorder specified as mild or in remission, certain polyneuropathy conditions, including Guillain-Barré syndrome, certain peripheral vascular disease conditions, aortic aneurysms without rupture, dependence on renal dialysis, and certain angina pectoris conditions. Of 829 diagnosis codes for HCC 59, major depressive, bipolar, and paranoid disorders, only 49% were retained. Not included in V28 polyneuropathy, angina, hypoparathyroidism, acute kidney failure, some aneurysm, and some aneurysms without rupture. Again, these are conditions that did not accurately predict medical cost. The coefficients were small. The conditions with unspecified or diagnostic coding criteria, as well as conditions that were uncommon. Now we'll talk about opportunities for improved specificity. So we will discuss the expected changes to some commonly seen and miscoded conditions. As always, Blue Cross North Carolina encourages accurate and complete coding of medical conditions that affect the care of our members. Coding accurately and completely will create an accurate picture of your patient population. When coding for major depression, unspecified should not be used when avoidable. The provider should specify the above in their documentation and assessment. This includes noting the severity or severe, mild, frequency, single episode, recurring episode. Are there psychotic symptoms present? And are they in remission? And if so, is it full, partial? Some major depressive disorders that will no longer risk adjust include a single episode of mild and partial or full remission, and a recurrent episode of mild depression and partial or full remission. Documenting and reporting accurate major depression severity, mild, moderate, and severe, will impact your patient's risk score in V28. Therefore, it is important to include all of that detail within your provider assessment notes. Okay, suicide attempts. The patient's healthcare team needs to be aware of the frequency and history of suicide attempts. This is a great example of when you would continue to code even though the HCC has changed. Although an HCC is not assigned to conditions such as suicide attempts, subsequent encounter, and personal history of suicidal behavior, proper care should be provided and appropriate referrals should be made to care for the individual, regardless of their HCC status. With the prevalence of dementia and associated conditions, the V28 model now includes an expanded list to include severity and behavioral disorders such as wandering. Some day-to-day situations can present safety issues for people with dementia. These include driving, cooking, and walking, or living alone. In these cases, social determinants of health conditions should be documented and coded for these people or these members. SDOH examples include Z55.6 for problems related to health literacy. That will include difficulty understanding current conditions, may enlist the help of a caregiver or family member as needed, so on and so forth. Okay, we have an example here, a scenario. So what would you code? You have an 84-year-old female, and in the assessment and plan notes, the physician has documented late onset Alzheimer's disease with behavioral disturbance. And then their note says continue to have ongoing progressive challenges with cognition and memory. Family support remains excellent. Discussed options including referral to neurology, stating donepezil, Aricept versus Namenda. Patient politely declines for now. Okay, let's take a look at what we would code. So for this example, you would code G30.1 and F02.81. The G30.1 will include the Alzheimer's disease with late onset, and the F02.81 will indicate the dementia and other diseases classified elsewhere, with unspecified severity with behavioral disturbance. Correct coding begins with clear, concise, and specific documentation. Whenever there is a condition with levels of severity, the provider should include within their documentation which level is pertinent to the patient. For example, this slide shows how to code asthma. So when a provider codes asthma, the documentation and the reporting should include whether it's intermittent, persistent, persistent mild, persistent moderate, persistent severe, will all need to be addressed accurately and clearly in the documentation for these patients. Okay, same idea here with regards to documentation and coding. Notice the change from HCC 111 to HCC 280 in the V28 model for these COPD conditions. A patient's COPD can be controlled and remain stable, but it should still be assessed and reported annually at minimum. When you are coding these, make sure you include any oxygen use for that patient. And as far as documentation, the provider will also need to indicate what type of infection, if that is affecting their current condition. Okay, we have another example here. So what would you code? You have a patient with a history of present illness of allergic rhinitis, COPD, hypoxia, and pulmonary fibrosis. The allergic rhinitis is current without significant symptoms, remains on Astelins nasal spray and Atrovent nasal spray. COPD is current without exacerbation, remains on an inhaler along with PRN albuterol. Let's see. And hypoxia remains on supplemental nasal cannula, oxygen at 2 liters. And pulmonary fibrosis, mild in degree. And then we'll follow up lung function testing in 6 months. So all of these are current. They're all receiving some sort of a treatment. So what would you code? You will code all of the associated diagnoses for this patient. As I mentioned, all are documented as receiving current treatment, and all will affect the care for this patient. All right, now I will turn things over to Missy to continue our webinar. Over to you, Missy.
Thank you, Tracy. Now we're going to talk about phantom limb syndrome. Phantom limb syndrome is a condition in which patients experience sensations, whether painful or otherwise, in a limb that does not exist. Patients who have experienced an amputation should be assessed for this condition and coded appropriately. Phantom limb syndrome with or without pain should be documented specifically by the provider and coded using G54.6 or G54.7. V28 includes expanded HCCs for metastatic cancer and a new HCC for myelodysplastic syndrome cancers and multiple myelomas. Documentation in the patient's chart should indicate if these conditions are in relapse, remission, or active. Also, many of these patients have received stem cell transplants in the past. These transplants should also be included in your coding. Cancer coding is challenging for everyone. Blue Cross NC performs internal data integrity audits on frequently miscoded conditions as outlined by the OIG and CMS. The second table on this slide is a snapshot of a recent data integrity audit for cancer coding. As you can see, prostate cancer and breast cancer are at the top of the list for frequently being miscoded. Both conditions are usually reflected as current conditions instead of historical conditions within documentation. Please query your provider if clarification is needed when coding these conditions. Diabetes codes have had multiple changes for V28. Drug-induced diabetes codes were removed from the model and other diabetes codes were moved to one coefficient. Diabetic eye disease and other eye-related issues are now included in HCC 298. Primary care providers should also follow up on test results from eye care professionals to include any new diagnoses for diabetic eye disease. Diabetes is a commonly seen condition and many of the treatments are known and recognizable. However, providers should be encouraged to indicate type 1 or type 2 and document any causal relationships with complications and treatments. Scenario time. The provider has documented a diagnosis of type 2 diabetes mellitus with stage 3A chronic kidney disease with long-term current use of insulin. The provider has also indicated the current treatment plan in their note. Let's take a poll for everyone to choose what they would code. In this case, you would code E1122 for the type 2 diabetes with chronic kidney disease. Then you are directed to code the kidney disease stage, which is 3A. It leads us to N18.30. And finally, you will use code Z79.4 to reflect the diabetes treatment of long-term use of insulin. Another change within the V28 model includes the removal of Z99.2 from a HCC category. Dependence on renal dialysis should continue to be coded, however, it is no longer reflected with an HCC. Chronic kidney disease ICD-10 codes remain the same, however, their HCC categories have moved from 136 to 138 to 326 to 329. When coding kidney disease, it is important to specify the stage, include the eGFR value, dialysis status and noncompliance, and SDOH codes as appropriate. Providers should also be encouraged to update these conditions in the problem list as they advance. For example, if a patient has progressed from CKD stage 2 to CKD stage 3, this should be documented clearly. And CKD stage 2 should be moved to past medical history with the resolution date to avoid confusion. All right, here's another coding scenario for us to practice with. We will pretend that there is a plan associated with each of these conditions that outlines their current treatments or impacts on current care. Let's look at the fifth and sixth diagnoses listed: ESRD, end-stage renal disease, and dependence on renal dialysis. The answer you would code is end-stage renal disease, which is N18.6. ICD-10 guidelines indicate you must also use an additional code to indicate dialysis status, Z99.2. So although the dependence on renal dialysis has been removed from the HCC category, it does not mean that you will no longer code it. It is still part of the patient treatment and requires monitoring and care. This is a great example of how ICD-10 coding doesn't change just because the HCC associated with the code has. Now let's move on to some general best risk coding practices. Your risk adjustment coding provider education and engagement team here at Blue Cross encourage provider groups to prepare for visits prior to the patient arrival. This helps to determine the patient's risk profile, identification of potential health risks, and providing appropriate interventions to avoid adverse events related to chronic conditions or treatments. Chronic conditions should be flagged in these patient charts to ensure that the provider remembers to assess and document the care for them. Some provider groups have an EMR with this capability, while others use reports and huddles to share this information. It is important to identify how these conditions are presented at the point of care to ensure that the provider has all the information needed to properly assess the patient. Discussing the presence of chronic conditions before the patient appointment is essential to the management of their chronic conditions. Pre-visit planning is a great way of cleaning up a patient's chart. Contradicting conditions found on the problem list can be flagged for review and examined by the provider during the visit. As we speak about best practices for capturing chronic conditions, it is important to be aware of additional tips for success. Providers should be encouraged to document all active diagnoses accurately and completely. This includes documenting resolution dates for conditions that are no longer active, as well as including what treatments are being used to manage the patient's chronic conditions. Medications should be linked with conditions within the assessment and plan. Conditions that are active without current treatment should include an explanation of why they are being monitored or how they impact other conditions and treatments. All of these things will help to reflect the medical necessity and clinical relevance of the patient's conditions. These practices will ensure that the past medical history and problem lists are updated frequently to accurately reflect the current status of each patient. We believe that high quality patient provider connections with accurate documentation and coding will lead to complete, accurate claim submissions. Throughout this presentation, you've heard us mention coding audits. Now let's talk about these a little more in detail. Blue Cross NC performs coding audits because we are mandated to ensure that the risk adjustment data submitted to CMS is complete, truthful, and accurate. Our data integrity team audits charts to ensure all CMS guidelines, regulations are being followed, as well as checking that diagnosis coding follows coding guidelines. When data corrections such as adds, deletes, and voids are needed, they are sent to CMS to support Blue Cross NC's attestation as to the completeness and accuracy of the data our team submits to CMS. Blue Cross performs two different types of audits related to risk coding. The first are data integrity audits, and the second are coding accuracy audits. Coding accuracy audits are specific to participating Blue Premier program provider groups. Your risk coding provider education and engagement team reviews the results of these audits to look for opportunities to provide education and coding resources to your teams. Blue Cross NC utilizes CMS, OIG, and industry guidance to identify potential high-risk coding practices. These are code sets that are frequently miscoded by the majority of providers. Data integrity audit projects for high-risk diagnosis coding practices run continuously throughout the year to ensure the accuracy of MA and ACA CMS risk adjustment data submissions. This slide shows the high-risk group errors for the OIG on the left. As you can see, these have high error rates that range from 81% to 96%. Our internal data integrity audits pull a random sample of all claims submitted with these associated diagnosis groups across all providers. Your team may or may not have updated feedback each month. It just depends on if you were included in the sample. These audits do not penalize your teams or affect your reimbursements within our programs. However, they should be considered when evaluating the performance of your practices as well as education offerings shared. Your risk coding provider education and engagement team will use these results to offer targeted provider education. Our team feels that if we increase education on these coding practices, it will lead to increased accuracy and increased success in managing the chronic health conditions of our members. Coding accuracy audits are performed on participating Blue Premier groups to confirm coding quality and accuracy to ensure that data submitted to CMS by Blue Cross NC is accurate and complete. These charts are randomly selected based on attribution and are performed in-house by our data integrity team. The results of these audits will be shared upon completion, and your risk coding provider engagement team representative will request to schedule a one-off meeting to discuss your results and how they relate to your current reports. These audits are used to identify coding trends, potential challenges, and opportunities for provider and coder re-education. Now that we've shared information about the types of audits our data integrity team performs, let's talk about what to do if you perform an internal audit and find codes not submitted on the initial claim. When additional codes need to be added or deleted, there are different options for your group. The preferred method is via corrected claim. The filing requirements for these are quite specific. Please review the information found in the link above to avoid rejections. Next, if your patient has more than 12 diagnosis codes to submit, have no fear. You will use the $0 claims process outlined in the link provided. Finally, you may submit MFT files for review through 12/31 or December 31st of the year following the service year for MA. ACA MFT file data submissions are accepted October 1st through March 31st, 2024 for 2023 dates of service. Blue Cross submission deadlines are rooted around CMS deadlines, so our team has ample time to process these requests. So we have covered a lot of changes and new information during this webinar. Rest assured, your risk coding provider education and engagement team is always here to support and help your practices improve their risk coding. Our team hosts monthly risk coding webinars. We have multiple one-pagers on our external risk coding website to use as quick references when coding, and we can also create individualized resources to support the needs of your team. I'll now pass it back to Kira to close us out.
Thanks, Missy. In conclusion, ICD-10 coding practices should not change based on V28 changes. You will continue to code patient conditions accurately and completely, regardless of the HCC status. V28 is a model change, not a coding guidelines change. We have enjoyed putting together this presentation for you today. Please send all your risk coding education inquiries and requests to our team using the provided email address on this slide. Thank you again for joining us, and we will see you next month for our phases of cancer on March 19th. Hope you all have a wonderful day. Also, please take an additional few minutes to complete our post-presentation survey by scanning this QR code, or you may fill out the survey you will be receiving via email. You can also use the QR code in this slide to obtain your CEU. We have also dropped links to our QR codes for easy access as well. I would like to thank our speakers today for their time and dedication, Tracy Cox and Missy Leggett. This concludes our webinar. We hope you have a wonderful day. Thank you.